that is human epididymis protein, which is a new tumor marker for ovarian cancer. So are we looking at a better marker? This is a prospective study in comparison with CA125. As we know, ovarian cancer is the 5th most common cause of cancer deaths in women, and it constitutes about 4%. It is relatively a manageable malignancy when diagnosed at an early stage. Till date, we know CA125 as a gold standard biomarker for ovarian cancer, but it has its own limitations due to low specificity and sensitivity. It is also related to tumor stage, so only 50% of the cases are diagnosed at stage 1. Increased CA125 is also seen in n number of conditions. So there is a need for multiple novel biomarkers like mesothelin, osteopontin, CA72.4, etc. But they all lack validation studies. HE4 has emerged as the most promising marker. HE4 belongs to Wave4 disulfide core protein. It is first identified in the distal epididymis. It is expressed in healthy epithelial tissues like reproductive and respiratory. It is overexpressed in ovarian cancer tissue. It is suspected to have a trypsin inhibitor property, but exact function is unknown. It is neither tumor nor organ specific. It also helps in calculation of ROMA, that is risk of ovarian malignancy algorithm, used to assess the risk of epithelial ovarian cancer in women presenting with pelvic mass. In the current study, we have included 36 patients who presented to the OP with a pelvic mass or suspected ovarian mass and who were advised for CA125 levels. 10 healthy controls were taken, 5 pre and 5 postmenopausal women. The inclusion criteria were patients above 18 years of age, pre or postmenopausal, presenting with pelvic mass. The exclusion criteria were patients below 18 years of age, pregnant women, history of smoking, presenting with abnormal renal conditions, already treated for malignancy or currently under treatment. All the cases were confirmed at a later date with the pathology report. The serum samples were analyzed for HE4 CA125 by ECLIA on Roche Cobas E411 and creatinine on Vitros 350. The statistical analysis used were SPSS software and MedCalc software. Coming to the results, we have divided all the cases into 3 groups, that is group 1, group 2 and group 3. Group 1 constituted ovarian cancer group, group 2 included benign conditions and non-ovarian malignancies, and group 3 is controls. Here we can see that the mean CA125 and HE4 levels were significantly elevated in group 1 when compared to group 2 or controls. Also we see that the mean CA125 levels were elevated in group 2 when compared to controls, whereas HE4 levels are within limits, indicating CA125 is elevated in many conditions. This is the FIGO staging where we see about 70% of the cases are in stage 3 or 4 with high mean HE4 and CA125 levels, whereas we encountered only one case in stage 1. Among the histological classification, the serous and the seromucinous type has predominated, which with high mean CA125 and HE4 levels. Here we can see the specificity and positive predictive value for HE4 is better than CA125, whereas sensitivity and negative predictive value is better for CA125. On combining both the markers, we see that the sensitivity of HE4 and specificity of CA125 has improved. This is Spearman-Rowe correlation, where we see that HE4 and CA125 individually are significantly correlating with the diagnosis. There is a positive correlation between HE4 and CA125 for all the cases with a significant p-value. In the receiver operating characteristic analysis, the area under curve for HE4 is 0.849 and is significant, whereas for CA125 it is 0.718 and is also significant, indicating a better accuracy of HE4 than CA125. When we try to consider only group 1, that is ovarian cancer group, the area under curve for HE4 has improved to 0.971 and is significant. To discuss, the present study has shown that there is high specificity and low sensitivity of HE4 when compared to CA125. Moore et al. Also showed the high specificity of HE4 and sensitivity was at par with the present study. Rosin DJ et al. Showed the high edge of specificity of HE4 at tissue level also. The CA125 sensitivity of CA125 is better than HE4 in the present study, since the current cohort consisted mostly of advanced cases of ovarian cancer. Montagne et al. Also concluded in their study that CA125 showed good discrimination between controls and ovarian cancer at later stages, whereas HE4 showed good discrimination even in early stages. Harlisky and colleagues showed that HE4 showed a better sensitivity both in early and late stages. The area under curve for HE4 is better than CA125, which is already shown in many studies. On combining both the parameters, the sensitivity and specificity has improved, which was also shown by Moore et al., Hattinen et al. And Miriam Leonard. When we consider all the cases, HE4 performed better than CA125, showing a good discrimination between ovarian cancer and group 2. But when we consider only group 1, area under curve for CA125 is better than HE4. Also, we have seen increased HE4 levels in 4 cases of endometrial cancer, indicating to be a marker of same. Similar findings were seen with Brennan et al., Moore et al., Hattinen et al. When we consider HE4 as a marker of both ovarian and endometrial cancer, the specificity has improved to 72.7%. Also, we came across 2 cases of COX which showed increase in CA125 but not HE4. A brief on Roma, it takes into account HE4, CA125 and menopausal status of the women. It is calculated by an online calculator and it showed a better sensitivity and a negative predictive value. Specificity was better in premenopausal than postmenopausal women. Overall, if we see the area under curve, the performance of HE4 is better than Roma than CA125. To conclude, both the markers are sensitive tumor markers with clear relationship to tumor stage and histology. HE4 showed better diagnostic specificity and area under curve than CA125. Probably HE4 is a better marker in early stages of ovarian cancer, and in late stages CA125 is equally a good marker. Anyhow, further studies are needed to explore in more detail. HE4 also is a marker of endometrial carcinoma. Roma also showed a better diagnostic performance. Finally, HE4 is a single good marker than CA125, and on combination the performance has improved, the performance is better than CA125 alone. These are my references. I would like to thank my team, technical staff and management, and thank you to the organizing team for giving me an opportunity to present my paper here.
Taken only 35, 10, 10.
Yes, ma'am. This is actually a pilot study. We have just started 3 months ago. We have taken the kit just 3 months ago.
Have you tested it in ascitic fluid? Does the kit permit you to test
Yes,
it?
madam. Since I have described here, most of the cases are advanced cases of ovarian cancer which also had an effusions. So I thought the effusion, if it is there's a paper showing that effusion will affect CA125 much more, and when I see literature saying for HE4, it has a little bit lesser effect on HE4. So effusion was common in all the cases of ovarian cancer.
No, but did you test this? Does the kit permit you to test in ascitic fluid?
In fluids it was not given, but in
Syscobas,
urine, yes ma'am.
Syscobas?
Yes ma'am. It is given for urine samples actually, but fluid it's not yet given in the kit insert. Probably it will work, sir. Yes, sir.
You said that for endometrial cancer also you have taken only 4 cases.
Yes, sir. Since my study included only 4 cases, but there are many papers showing that endometrial can be used. Yes, yes. Madam? Since the group 2 consisted also endometrial cases. So there were 4 cases where HE4 was elevated, but in only 1 case CA125 was averagely elevated. It was around 60.
What is the term averagely?
It is around 60, madam, actually.
I have a question for you.
What is your cancer, the sample size for CA prevalence, taking prevalence into account?
Here, sir? Here it is around 22 cases were for ovarian cancer, sir, out of 36.
You calculate the sample size required.
No, this is a pilot study, sir, actually.
It's all right, but you calculate other things.
No, I didn't calculate.
This is a cross sectional. If you do a case control, probably this could be the sample size itself.
Yes.
Right? That takes care of. One question just to see. Epididymal tissue is not present in human. So why do you get this?
The name came from, since it is first identified in epididymis, but there are no papers or literature saying that it is useful in some epididymal lesions. Or in papers show that.
What is the origin in these patients?
Sir?
What is the origin of this in these patients? What is the origin of this HE in female patients?
Region.
Origin.
Origin. Epithelium, sir.
How the Roma behaved in premenopausal and postmenopausal.
Yeah, Roma performed better in premenopausal than
And
postmenopausal. The area under curve was better for premenopausal than postmenopausal.
what you
The specificity itself was better in premenopausal also.
and overall the HE4 plus CA125 we have better marker than HE4 individually and CA125.
No. I have given HE4 alone is a better marker. If at all there are 20% of the ovarian cancers which do not express any of the markers. So in those cases probably HE4 would help much better than CA125. So if at all even we are missing for HE4 marker, then on combining both the markers probably we will try to reduce the 20% which are biomarker negative for ovarian cancer.
But in your study, comparing the both, there is a very good sensitivity
Yes.
compared to HE4 and CA125.
See, there is a discrepancy, like there is a differentiation in the results. Like the specificity, when I have seen it is better in premenopausal than postmenopausal. Whereas if I see the sensitivity results, it is better in postmenopausal than premenopausal. Also, it is differentiating with the stage of the ovarian cancer. So, as the stage increasing, the CA125 was showing a better sensitivity when compared to HE4.
In the literature, they have mentioned that in premenopausal state, HE4 performed the better when
Yes.
compared to CA125.
Yes.
So that is one I want to add.
Correct.
Made a statement that in COX was
Yes, ma'am. So, CA125 was raised.
CA125, the second line is importance is lung cancer.
Yes.
You rule out lung toxicity or you propose that it was not?
No, it was ruled out.
Why you have done creatinine in enzymatic method, but you have not mentioned anything word about that in the. But you have done creatinine.
Yes,
Why?
sir, because I just want to rule out any abnormal renal conditions present. Because if there is any abnormal renal conditions, the HE4 as well as CA125 is both elevated. Very high levels are seen in abnormal renal conditions.
Because in renal conditions,
So
HE4
just to
will
rule
increase.
out, yes sir, definitely.
But here you have not means compared.
Actually, I have mentioned it in exclusion so that I will take out, exclude all the abnormal renal conditions there.
Okay, thank you, Dr. Jyotsna.